And now we will start the last session of the first day of our conference with the Professor SHAYMAA ELSAYED and the lecture titled Cardiovascular Trials and Diabetes Management. The recorded lecture.
Hello, everyone. I'm happy to be with you today about the cardiovascular trials and diabetes management. I'm Dr. SHAYMAA ELSAYED, consultant cardiologist at Salam Specialist Hospital, Bahrain. I'm so happy for kind invitation from my professor, Dr. Ines Shaltut, for the participation in this successful event and congress for Arabic Association for the Study Metabolism of Diabetes and Metabolism this year, 24. My agenda today is diagnosis of diabetes mellitus, pre-diabetes, cardiovascular risk assessment in patients with diabetes and pre-diabetes, prevention of cardiovascular disease in patients with diabetes and pre-diabetes, clinical trials and diabetes management. Diagnosis of diabetes mellitus according to guidelines ADA 2019, it is recommended to screen potential type 2 diabetes mellitus in patients with cardiovascular diseases initiated with HbA1c and fasting blood sugar, and that of OGTT in the patient if HbA1c or fasting blood sugar is inconclusive. For recommendation of OGTT is used for diagnosis of impaired glucose tolerance test and recommended to diagnose the diabetes mellitus based على HbA1c or fasting blood sugar, OGTT if still doubt, class 1 recommendation. However, there is limitation for HbA1c to be considered, such as interference in the result of hemoglobin variants and anemia. In acute coronary syndrome, OGTT should not be performed earlier than 4 to 5 days to minimize false positive results. And my second point in my agenda, cardiovascular risk assessment in patients with diabetes and pre-diabetes, cardiovascular recategorization in the patient with diabetes, very high risk, moderate risk. High risk, very high risk patient diabetes, established cardiovascular disease or target organ damage or 3 major factors, early onset of diabetes mellitus, more than 20 years, high-risk patients that diabetes duration more than 10 years without target organ damage, plus or additional risk factors. High-risk patient, moderate risk patient, consider young patient, type 1 diabetes mellitus aged less than 35 years old, or type 2 diabetes less than 50 years, with diabetes mellitus less than 10 years without risk factors. About the recommendation for the use of laboratory microalbuminuria as routine assessment is indicated in identifies patient risk for developing dysfunction for the renal in the very high risk or high risk group of future cardiovascular diseases. Resting ECG is indicated in patients with diabetes mellitus, with hypertension, or with suspected cardiovascular diseases. According to assessment of carotids or femoral plaque, should be considered as a risk modifier, as well as calcium score or CT coronary angiogram and brachial index. All of these are considered risk modifiers, class 2A, but not a routine investigation for all patients with diabetic mellitus. Meta-analysis on the 5 randomized clinical trial on about 3,000 patient asymptomatic diabetes mellitus showed non-invasive imaging for the coronary artery disease not significantly reduce the event rates of non-fatal MI and hospitalization of heart failure. According to the routine screening of coronary artery disease in asymptomatic diabetes is not recommended. However, stress imaging or CT coronary angiogram may be indicated only in very high-risk patient, asymptomatic or peripheral arterial disease or high calcium score, proteinuria, or renal impairment. Cardiovascular risk stratification in the pre-diabetes patient without cardiovascular disease warrant risk scoring cardiovascular disease in the same way based على army score system, CKD, familial hypercholesterolemia, other risk factors. So cardiovascular risk categories according to ESC guidelines 2019, very high risk patients, that people has evidence of atherosclerotic cardiovascular disease, PCI or CABG, diabetes mellitus with target organ damage, at least the three major factors, risk factors: early onset of type 1 diabetes mellitus, more than 20 years, and the severe CKD, HFR less than 30, calculated score more than 10%, familial hypercholesterolemia with atherosclerotic cardiovascular disease, or with another major risk factor. High-risk patient category is people that markedly elevated the total cholesterol, patient with familial hypercholesterolemia without other major risk factor, patient with diabetes without organ damage, or diabetes more than 10 years without target organ damage, or moderate CKD, or calculated score 5 to 10%. Moderate risk factors or moderate cardiovascular risk category, patient with type 1 diabetes less than 35 years, and type 2 less than 50 years, diabetes mellitus duration less than 10 years, and calculated score 1 to 5% of fatal cardiovascular disease. Low risk is less than 1% of calculated score. Third point is prevention of cardiovascular diseases in patients with diabetes and pre-diabetes. As we know, prevention can be for the patient with diabetes or pre-diabetes, can prevent the patient to be enter in diabetes sickly, like lifestyle modification, glycemic control, blood pressure control, management of dyslipidemia, antiplatelet therapy. Smoking as a lifestyle modification is very mandatory, and the class 1 indication recommended lifestyle intervention and they prevent the conversion to pre-diabetes, as well as body weight reduction, physical activity more than 150 minutes per week, diet as Mediterranean diet, DASH diet, high vegetables, fruits, and also recommended to glycemic control, HbA1c less than 7%, to prevent microvascular complication, as well as HbA1c targeted individuals to be suitable for the aged patient to prevent hypoglycemia, and self-monitoring in the house is very important to control the blood pressure and HbA1c. And targeted HbA1c target less than 7% can also prevent macrovascular complication as a class 2A. HbA1c target 6.5 is very important and considered on the basis to achieve without hypoglycemia 8 to 9% in elderly advanced comorbidities, hypoglycemia predisposed for ischemia and arrhythmias. And the last point in my agenda is clinical trial and diabetes management. What is the classification for the antidiabetic drugs? We have insulin sensitizers like metformin, pioglitazones, insulin providers, insulin sulfonylurea, incretin-based therapy, GLP-1, DPP-4 inhibitor, and gastrointestinal glucose absorption inhibitor like acarbose, renal glucose reuptake inhibitor, SGLT2 inhibitors. This is the trials of cardiovascular safety trials with diabetes management from 2013 and 2020, a long journey with DPP-4 inhibitor cardiovascular outcome trials like SAVOR, Examine, TICOS, Omnion, and Carolina. For SGLT2 inhibitors, Impareg, Canvas, Credence, and it will add GLP-1 receptor agonists like Alexa, Leader, Sustain, as well as Rewind. Incretin are GIT hormones that stimulate insulin release from the pancreas and include glucagon-like peptide and gastric inhibitory polypeptide. And these hormones are metabolized by dipeptidase DPP-4 enzyme. For the type 2 diabetes mellitus drug name naive and the patient not on metformin before, this patient, we will risk stratify them. If the patient is very high risk or high risk with atherosclerotic cardiovascular disease, we should start from the beginning as GLP-2 inhibitor or GLP-1 and reach to the target. If not controlled, we can add metformin. If the patient has no evidence for atherosclerotic cardiovascular disease, the patient is moderate or low risk, we can start with them metformin therapy as it's called a cornerstone. And if the patient HbA1c is still not controlled, we can add one of the new era DPP4, GLP-1, SGLT2 inhibitors, and DCTs. And according to the follow-up, we can reach to the target. Type 2 diabetes on metformin, this patient, we will ask and stress stratify the patient. Has atherosclerotic cardiovascular disease, high or very high? And with metformin, we can add on SGLT2 inhibitor or GLP-1 receptor agonist. And still reach the HbA1c according to the follow-up of the patient. If the patient has moderate risk or low risk and no evidence of atherosclerotic cardiovascular disease, continue metformin for this patient. And if the HbA1c in the follow-up is not reached to the target for you, add one of the new era DPP4, GLP-1 receptor agonists, SGLT2 inhibitors, or TZTs according to the patient. So from the guidelines, it is class 1 indication for empagliflozin, dapagliflozin to reduce cardiovascular outcomes, and empagliflozins can reduce the risk of death, as well as liraglutide and dulaglutide are decreasing the cardiovascular deaths and very important in very high cardiovascular risk, class 1 indication. Biguanides is metformin is considered for overweight and moderate cardiovascular death risk patient. Insulin can be added for the glycemic control as class 2A if the patient with acute coronary syndrome and high glucose level more than 180 milligram per deciliter. Saxagliptins are not recommended in patients with type 2 diabetes mellitus and high risk of heart failure. What are the benefits from SGLT2 inhibitors versus GLP-1? Reduction of cardiovascular events for both are very good. Mortality benefit with empagliflozin and the liraglutide. Reduction of heart failure and hospitalization with SGLT2 inhibitor, not GLP-1. Renoprotective for both and blood lowering effect for both, as well as weight reduction. So SGLT2 inhibitors, empagliflozin, dapagliflozin has associated with renal endpoints, low risk with eGFR 30 to 90 class 1 indication. Treatment with GLP-1 receptor agonist, liraglutide and semaglutide has low risk for the renal endpoints and should be considered if the diabetes treatment eGFR more than 30 class 2A. Landmark trials that shows that the cardiovascular benefit from SGLT2 inhibitors, most prestigious trials like empagliflozin, EMPA-REG, dapagliflozin declared, DAPA heart failure, dapagliflozin, CANFAS, and CREDENCE. For the GLP-1 receptor agonist, semaglutide, sustain, albiglutide, harmony, liraglutide, leader, dulaglutide, rewind. Then the landmark trials for DTP4 inhibitors, sitagliptin, TICOS, linagliptin, Carmelina, Carolina, allogliptin, examine, saxagliptin, SAVR, TIMI, P3, increase heart failure effect. As well as the management of blood pressure, as we can control as well as blood pressure by targeted the patient that diagnosed more than 140/90, and the blood pressure should be less than 130, diastolic less than 70. And the lifestyle modification as well as its inhibitor are very important in diabetes to decrease the presence of albuminuria, microalbuminuria, proteinuria, LVH, as well as combination RAS inhibitor with calcium channel blocker or diuretics for the patient uncontrolled or severe hypertension. Dual single pill combination are very beneficial and recommended by ESC guidelines. To benefit of the different PP targeted less than 140/90, reduction of stroke, coronary events, and kidney disease. Systolic blood pressure 130/135 is reduced risk all causes of mortality by 13%. Systolic blood pressure less than 130 is greater reduction in stroke. Number 4 is the management of dyslipidemia for the patient that type 2 diabetes mellitus with moderate cardiovascular risk factor. We can reach the LDL cholesterol to the target less than 100 milligram per deciliter. If the patient type 2 diabetes mellitus with high risk, cardiovascular risk factor should be less than 70 milligram per deciliter. Patient with very high risk cardiovascular risk, LDL cholesterol should be less than 55 milligram per deciliter. It is class 1B recommendation. Statin therapy is recommended as a first choice, and we can add on ezetimibe recommended combination therapy, FDL, LDL, cholesterol not targeted. Very high risk cardiovascular diseases, acute coronary syndromes, or familial hypercholesterolemia is still not targeted LDL cholesterol with maximum tolerated statin dose combination with ezetimibe recommend class 1A indication to give them PCSK9 inhibitors. According to antiplatelet therapy to control management of diabetes mellitus, assigned aspirin 100 milligram daily versus placebo. It is trialed on 15,000 more than 40 years with diabetes and free from cardiovascular. What are the benefits? Reduce risk of serious vascular events, but increase the major risk bleeding. So primary endpoint for the MI ischemic stroke, TIA, but 12% with aspirin reduction, but there is counterbalance at 29% increased bleeding. So ESC guidelines recommend as class 2B for the high risk, very high risk patient diabetes, baby dose aspirin, and if there is no clear contraindication, and it is not recommended in moderate cardiovascular risk. And for my summary for this lecture is treatment targeted for the management of patients with diabetes, blood pressure control, glycemic control, less than 7%, and less than 6.5% for the patient categorization without significant hypoglycemia, and 8 to 9% for the frail elderly patient. Lipid profile as well as very high risk patient should be targeted less than 55, high risk less than 70, moderate less than 100. Platelet inhibition recommended only in high and very high cardiovascular risk factor, and the smoking cessation is obligatory. Physical activity more than 150 minutes per week. Weight reduction is important and can subject to impaired glucose tolerance and dietary habit DASH and Mediterranean diet. Thank you for attendance and thank you for kind invitation. I'm happy for any question. Thank you. See you inshallah next year.
Importance of risk assessment, cardiovascular risk assessment, and prevention in pre-diabetes and diabetes management. Professor SHAYMAA is with us online. If there is any question from the audience. إذا كان في أي سؤال يا جماعة الدكتورة شيماء معانا online. Okay. تمام. Okay. Okay. Thank you, Professor SHAYMAA. Thank you.